Good morning, everybody. We'll be getting started soon. My name's Sean Pegg. I am Director of Social Policy and Strategic Initiatives at Community Living Ontario. Before we get started, we want to learn a little bit about you. So you'll be seeing some polling questions coming up in front of you. So if you could have a look at those and let us know who you are, that would be great. Just a little bit of housekeeping before we get started. We're going to be taking questions during the webinar, but only through the chat function. So if you have questions, go into the chat on in your webinar screen and send your questions to organizers and panelists. That will help us get through the questions, and the organizers and panelists will all be able to see them. Once you ask a question, we'll go through them. You don't have to ask it more than once. We'll see how many questions come up and how many we can get through in the time we have. I think that's all of the housekeeping. So I'll turn it over to Chris for some introductory remarks.
All right, thanks, Sean. Good morning, everyone, and thank you so much for joining us today. My name is Chris Beasley. I'm the CEO at Community Living Ontario. Now more than ever, it's incredibly important that we come together as a community to learn from each other and strengthen our movement. I know that those attending this webinar are busier than ever, facing any number of personal and professional challenges, so thank you for choosing to spend time with us this morning. We've had more than 600 people register for this session, which shows that there's a real hunger for information about COVID-19 as it relates to people who have an intellectual or developmental disability and their families. Before we get started, I'd like to take this opportunity to provide an update on the work of the Provincial Network on Developmental Services, which has been meeting almost daily to strategize ways to address the challenges posed by COVID-19. The provincial network includes leaders from across the sector, and our meetings have also included senior representation from the provincial government. We've heard loud and clear from our frontline local associations that developmental service professionals need to be designated as essential workers, as is the case with healthcare and other frontline workers. We know that you need access to adequate personal protective equipment and increased financial support. We are advocating strongly on each of these issues. And while we were pleased with the $40 million in additional funds recently announced for the sector, there's still much more to do. We also know that people and families are under more stress than ever, coping with social distancing, isolation, and the challenges they pose. Please know that we are bringing these issues to government as well. And if you want to stay up to date on these and other developments, please make sure to sign up for Community Living Ontario's Update Friday newsletter. You can also access our new Staying Connected resource hub on our website, which is updated regularly with information related to COVID-19. Okay, let's get started. We have 4 speakers with us today who are leaders in their field and who will provide guidance on supporting the health of people who have intellectual and developmental disabilities in this very uncertain time. Joanne Demick is Executive Director of Community Living Parry Sound. She's also the chair of the Community Living Ontario Executive Director Coordinating Committee and brings an incredible wealth of experience and knowledge in the developmental services sector. Dr. Bill Sullivan works as a family physician in medical services at Surrey Place in Toronto, and is the founding director of the organization's Developmental Disabilities Primary Care Program. He also teaches in the academic family health team at St. Michael's Hospital. Dr. Yona Lunsky is director of the Healthcare Access Research and Developmental Disabilities Program at the Centre for Addiction and Mental Health in Toronto. She is also the director of the Israeli Adult Neurodevelopmental Centre and a professor in the Department of Psychiatry at the University of Toronto. Lastly, Brendon Pooran is the founder of Pooran Law. Brendon has been involved with various disability organizations as a member, volunteer, and director for most of his life. He created Pooran Law to provide support to this community and to influence disability law and policy throughout Canada. So you didn't sign up to listen to me, so let's get things started. And I believe Joanne Demick will be leading off. Take it away, Joanne.
Okay, I just need, oh, here we go. Good morning, everyone. Can you hear me okay?
Yep, we can hear you, Joanne.
Okay, thank you. Good morning, everyone. I have been asked to share with you a service provider's perspective on supporting the health of people during COVID-19. So, well, as we're talking about supporting the health of people, this must include people's mental health as well as their physical health. And I will talk a little bit about that in my presentation. So this is the CLPS story, the Community Living Parry Sound story. What we've learned to date is that the situation is fluid and constantly evolving. Information at times can feel overwhelming. Important that agencies are thinking proactively, several weeks out, anticipating what might be needed as they respond rapidly. Communications are also critical. At Community Living Parry Sound, we have moved to daily video conferencing. In the morning, our management team meets via video conference at 9 a.m. and at 3 o'clock every day, our community teams meet to share communications. So just need to. So CLPS had introduced technology 2 years ago, and we were able to create a mobile workforce. All of our staff had, prior to the pandemic, had laptops and iPhones, and our software was web-based, so it could be supported anywhere. We have a neutral planning and facilitation team that was engaged with person-directed planning. And as a result of the pandemic, we were unable to continue meeting with people and doing plans. This team was redeployed to engage in daily wellness checks. Their role was to enhance the support services to families and people by making daily calls to support people coping with the stress of isolation, fears, and anxieties due to the pandemic. Their primary function was mental health supports. Wellness calls are currently an enhancement to direct supports. However, it is now well established with solid relationships. And if we need to transition from direct personal supports to virtual supports, we have a wellness team in place to do that. We have been engaged in wellness checks since March 16th. iPhones and iPads with data have been provided to people that we support so that they can remain connected while staying at home. And although there is a sense of isolation and loneliness, the video calls have certainly helped. We have a dedicated support professional who has gone in and assisted people with this technology and has taught people how to download apps, text messaging, connected with family and friends, so that although people are in isolation, they still have that circle of support. All of these devices are on loan from CLPS and will be replaced if the person so chooses once the new passport guidelines for eligibility come into effect. The situation has been fluid and every day brought increased precautions. We moved rapidly to full lockdown on our group homes and dedicated staff teams with no cross-programming. So although we had staff who perhaps worked in a group home, but delivered passport supports to someone living in community, that no longer happened. We have dedicated teams. There is no cross-programming. We have talked to all of our employees who have had employment outside of community living Parry Sound, and particularly within our group homes, we have asked them to choose an employer. If they chose to stay with their employer, we would redeploy them to a situation where people were less at risk. We've developed a partnership for home delivery of groceries and essential items. This was established with Rotary and Sobeys. All the group homes receive home delivery of food, as well as the people who live in their own apartments. We've also created a CLPS market here at our main building, where we have a food bank established. All of the personal protective equipment is on display and readily accessible to staff. And we have a huge amount of boredom buster activities. Staff have been informed that they are not to go into stores for work purposes. If there are items that staff require or that people that we support require, we will order them and we will have them shipped in. The home delivery of medications and online banking has also been initiated with people that we support. We fully anticipate that grocery stores, pharmacies will become the sources of community spread. And our focus is to keep people safe and out of these places at all costs for work-related purposes. Sorry, just, oops, how do I go back? Sorry. So this is Richard. Richard prepared us for what we needed to know and how to respond. Richard woke up on Saturday morning on March 21st with labored breathing and a fever. He was accompanied to the emergency room with his support staff and was tested for COVID-19. After which he was sent home to self-isolate, and we were informed that all of the staff that had been involved with Richard were to go into self-isolation. Well, if you can imagine a small agency like ourselves, we don't have teams that can rotate in. So we contacted public health, and we were informed that by public health that the medical officer of health has deemed and is supportive that at this time, employers can make the assertion that their workers are in fact essential service workers if their service is critical to the health and safety of vulnerable individuals. So that is exactly what we did. We deemed our staff as essential service workers. Richard was to self-isolate in the group home, which was not difficult other than the emotional impact that it had on Richard. So really, in terms of being proactive and thinking ahead, strategies need to be developed to support people during self-isolation. Communications at this time were initiated immediately with staff, board members, and our union OPSU. Again, communications are critical. One of the biggest challenges that we had was the wait time for the test results, which was 7 days. As you can imagine, 7 days of PPE use was very difficult on our precious commodity. It has been extremely challenging. This has been one of our greatest challenges, is just trying to get enough personal protective equipment for all of our staff. So what we have done is we provided letters for staff and for people who live in our residential programs to ask for priority testing by checking off section 7 on the lab requisition. We have provided those letters. We actually tested it out this morning, and we were told that the priority testing is 3 days for doctors and nurses. So it's better than 7, but 3 days is still a long time as we wait anxiously for test results. So hopefully the enhanced testing strategy that was introduced on April 10th will shorten this time. Effective immediately after our staff were designated as essential service workers for the duration of the pandemic was put in place. If a person is providing care to someone with COVID-19 and is healthy and well and not showing any symptoms, they are required to self-monitor for the symptoms, including taking their temperature twice a day. But they can continue working. CLPS deemed all the employees as essential service workers on March 21st. On March 23rd, the Board of Directors, without hesitation, approved a one-time $500 lump sum payment for all active employees, as well as a shift premium for all active employees required to attend a physical workplace. The additional $2 per hour was to compensate for the psychological and physical risks staff would face during the pandemic. All of this was done upon legal advice that we were still in full compliance of Bill 124. In addition to this, the Board of Directors sent a letter to all staff commending them for their exceptional work and expressing their deepest gratitude. So our focus initially were on 3 Ps. People, really trying to make sure that our staff were well supported, obtaining personal protective equipment, and finding a place for self-isolation. So with our people, the employees were all notified that there would be enhancements made to the collective agreement. Communications again was critical. Each enhanced precaution or protocol was delivered in writing by Executive Director and copied to the union and the Board of Directors. Staff teams were tightened. There's no cross-staffing at different work sites. Staff working for other employers were asked to choose. And then effective April 7th, all direct support staff were required to wear masks during active involvement with people when delivering support services. Staff actually welcomed the tightening of teams. We made an error in terms of scheduling, and we were immediately called upon it. I think it provides the staff with a sense of security that they are able to do better infection control. A decision-making tree was developed with the assistance of Christian Horizons, and we are absolutely grateful to Eugene and Janet for their assistance in helping us develop this. And this was implemented on March 23rd. Step 1, there were 3 different decision-making trees. Step 1 was guidance on COVID-19 exposure scenarios. Step 2 was guidance on supporting someone who is suspected to have COVID-19. And step 3, guidance on supporting someone who has COVID-19. We have 2 large tables in our team space in our main building, and all of the personal protective equipment is laid out there for people to access at any time. All of these decision-making trees are there. We have equipped all of our vehicles with personal protective equipment and the decision-making trees as well. Employees have been reminded of our assistance program, our employee assistance program, and encouraged to access it. We have provided all of our employees with a letter in the event that there are travel restrictions. And if they are pulled over by police asking where they're going, they can provide that information. Employees, again, are directed to not go to public places for work-related purposes, but to the main building for food, personal protective equipment, and all the arts and crafts supplies and books and activities that we can support people who are in isolation. We've really tried to, we've called them boredom busters. We've really tried to customize people's interests. Every day during our wellness checks, people are asked, what would they like to do? What do they need anything? What can we bring them? And that information is fed back to our direct support teams, and we provide all of that equipment through our main building, and then it's delivered by our direct support staff. Staff only need to ask for items which are ordered and then delivered. So keys to effective and immediate response. Keeping staff physically protected, financially secure, and feeling appreciated. I'm so proud of the work that our staff have been doing. Their dedication and their courage is just unwavering. We've been dealing with a lot of other challenges, as I'm sure everyone is. We've had cancer diagnosis during this time, other very difficult support situations, but our staff have just demonstrated how resilient they truly are. So the innovative supports for people through the use of technology and daily wellness calls has been really, really tremendous. And people have really appreciated being able to read the newspaper on their iPads, staying in touch with their family, texting with friends. When we started this, there's a number of people that we simply support through Passport, and they didn't even have a telephone. So we wanted, it was critically important to us to make sure that we could remain connected to people throughout this pandemic. So keeping people supported at home by coordinating grocery and medication deliveries to their homes, creating a CLPS market full of groceries delivered by Rotary to the CLPS site to keep staff safe and out of grocery stores, keeping people busy at home and active and enjoying it, entertainment, books, movies, art supplies. Finally, in terms of the place, we have identified a location that can be prepared should a person's home not be the best place for self-isolation, but we will work with public health should that need arise. We are also currently speaking to local hotels to provide rooms for staff during the outbreak should they not want to go home at the end of their shift. If they want to keep their, if they don't want to go home and perhaps risk spreading the virus to family, then we will provide other accommodations. So during, we recognize that celebrations and traditions are so important to people that we really made an effort. This is a photo of our team space loaded up with Easter supplies. So Easter gifts were delivered to every person and every family that we support. So our partnerships have been critically important during this time. Working with a manager from our local nonprofit housing, we have some significant concerns about this one housing development, and we're currently working with the housing manager to develop safe strategies for people who may not be physically distancing themselves. We're partnering with the OPP and communications. One of our biggest challenges right now is keeping people home and practicing physical distancing, which is not always happening. So the community policing has been fantastic to come and speak to people, working with our town and bylaw officer. The partnering with Rotary has been fantastic for home deliveries of Sobeys groceries. Rotary has also been making handmade masks for us when we cannot obtain all the surgical masks or healthcare masks that we need. We are relying on handmade masks. Our local food bank has been wonderful and is also transitioning to home delivery. So one of the biggest challenges, though, that we are facing right now is just for people living in community and really trying to encourage them to stay home. It's a very difficult time for them, but we're very concerned that should they become infected, that they may continue to go out into stores and other public places. So prevention is our best defense. This is a photo of our PPE table, and we are working, that is our entire focus right now, is just prevention of infection. So that's it for my presentation. If anyone has any questions, I'm sure 6 months down the road from now, our stories will be very different, but that is where we are today, basically 1 month in.
Well, thanks, Joanne. It's Sean here. We do have some questions that have come in for you. We probably won't be able to get to all of them, but we can get through as many as we can. The first one is it possible for community living agencies to provide masks and gloves and/or hand sanitizer to their clients who live in the community?
So, I mean, every community living agency is unique and it's different, and I'm sure it's dependent upon supplies. But we have already started that. We do provide masks and hand sanitizer and gloves to people that and families that we live in the community. Just really encouraging the best practices that Dr. Teresa Tam has recommended, that people wear masks. So again, yes, we do provide that personal protective equipment to people that we support.
Okay, thanks, Joanne. We had a couple of questions around PPE. One question says, we have staff who insist on using masks while working in group homes with our clients without symptoms. How do you suggest we respond to them? We are trying to limit full access to masks, and they feel we are denying them access to PPE.
So as an agency, we've shifted, and all of our staff wear masks when they are working in the group homes and providing personal care to people. And that has been some learning that has come out of long-term care facilities, that although the long-term care facilities have been locked down, the COVID-19 virus has infected people. So it's suspected that it's coming in with staff. So as a precautionary measure, the long-term care facilities are requiring people to wear masks, and we have followed suit. So anyone who is providing direct support services within our agency is wearing a mask. Again, they don't have to be the good masks, they can be the handmade masks. We're getting tons of donations of handmade masks, and those are, you know, when there's not an infection present. PPEs are precious. They're in such limited supply, but we've definitely been using the handmade masks. Some staff have opted to bring in their own masks, and we do have a small supply of surgical masks.
And Joanne, we've had a couple of questions about how you manage access to PPE in general.
So one of the things that we've done is we've tried. We have a full-time person who is dedicated to procurement. She's on the phone all day long, sourcing out whatever PPEs can be found. And we have a supervisor who assists her with that. The PPEs are out, they're visible, they're freely accessible. What we don't want our staff to feel is that they're not safe, that they're not protected, that PPEs are being restricted. The only item that is restricted at this time is our N95 masks, and those are not out in the main area. But certainly all the gloves, all the surgical masks or the handmade masks, the hand sanitizer, we've got gowns and jumpsuits, all of that is readily available, because if a person is going out into the community, they may encounter someone who is sick. We can't predict that. Our vehicles are equipped and our staff are fully equipped.
Okay, so we have to move on just in the interest of time, but I think there's a great question here about how everyone in your organization is coping, staff, management, board, volunteers, particularly when we can't predict when the pandemic will be over and things will go back to normal or semi-normal. Can you talk a bit about how you guys are coping?
So at this time, we are coping extremely well. You know, I'm so proud of the work that our staff are doing. They are so courageous. Everyone has really stepped up. We had one staff member who, for health reasons, couldn't continue coming into work, and she's back today and couldn't wait to get back to work. So we are coping well. We do not have a positive COVID test, so things, you know, as people become sick, that might change. But at this point, we're coping very well, and I thank whoever asked that question. I really appreciate you checking in with us to see how we're all doing.
Okay, thank you so much, Joanne. That's incredibly helpful. So we are going to move now over to Dr. Sullivan.
Thank you very much. And I'll just begin by asking whether I should control the screen or perhaps the presenters, the staff. So what I might do is just begin by showing my screen. I guess just to say that I am a family physician working at St. Michael's Hospital and Surrey Place Center. And I have worked a lot in the area of this intersection between general health care and the healthcare of people with intellectual and developmental disabilities. Now, can you see my slides just to confirm that?
Yes.
Okay, great. I guess what I'll do is I'll just put them into good. So I just thought I would begin by encouraging people to ask questions, because, and I'll try to be as brief as possible so that there is time to answer questions, which is, I think, key to this. And if there isn't sufficient time, we will have those questions after, and they're very important for us to better understand what people are actually thinking and worried about. Just to begin by kind of making sure that we're all sort of on the same page in terms of thinking about this virus. I think this image that it is a long, windy, and bumpy road ahead of us. And I'll just make a few comments about where we are on that road, and also, you know, what we can expect in the next while. So as people know, this COVID virus, it's caused by a virus that causes these symptoms that we refer to as COVID. And one of the problems is that it spreads quickly. And some people who get this infection, of course, will become have serious respiratory problems, and some of these will die. That's the big concern. In Ontario, I just checked these statistics recently that there are 13 million people, and as of yesterday, 7,500 had been infected so far. And of those, about half of them, 3,357, had fully recovered. And there are others that are still in the process of recovering, and about 291 people had died. And the other important number is that the rate by which infections are increasing is itself slowing down. And so these numbers are actually not easy to interpret, but it's the trends. And the other important thing is to know that on this road, we are right at the beginning. And that really what is being, the effort is at this stage to sort of minimize the number of people that get very sick so that the system is not overwhelmed. We're hoping that in time there will be sort of an effective vaccine and an antiviral treatment. I think the other thing that we've been talking about are all the precautions that are taking place at this time that have to do with social distancing to reduce the risk of infections and isolation measures. These are possibly going to need to be relaxed at some point and maybe reinstated. And this is where you get the bumps ahead. We're still learning a lot about this particular virus. We should remind ourselves that we only heard about this 3 months ago. And that's why there's still a lot of learning to be done. And our public health and healthcare responses will need to adjust rapidly to changing information. So in short, we're on a road through this pandemic that some say will last a long time, 12 to 18 months. That's kind of what is predicted by the time that there will be an effective vaccine. And it'll have many winds and many bumps. But I think the main point for the healthcare of people with intellectual and developmental disabilities that I want to emphasize is that we should not be overly anxious or afraid. We have part of that fear is the lack of control, and it's true that in these uncertain times there is an uncertainty, but there are also control measures that are on the horizon for this pandemic. And there can be good news that comes out of this. For example, more attention paid to the importance of addressing the health needs of people with intellectual and developmental disabilities, greater involvement of people with intellectual and developmental disabilities in decisions regarding their care, and better advanced planning and integration of care. And so as a society, we need to commit to all three of these goals, especially during a pandemic. So what can we do about this? I'm going to kind of suggest three things. Educating ourselves about the health vulnerabilities and needs of people with intellectual disabilities, especially during this pandemic, and ensuring that supports are adjusted to meet those needs. The second is to make use of innovations that will be happening, including the use of databases and virtual care to improve the integration of healthcare plans. And then finally, engaging people with intellectual disabilities as much as possible in developing such plans. So I'm kind of shifting from the notion of the very early phase of this pandemic is all about kind of preventing infections to beginning now to think ahead. So I just wanted to highlight very quickly some of the vulnerabilities of people with intellectual disabilities during this pandemic. And I think that Joanne's example illustrated a number of these. So there's a high prevalence of comorbid health conditions. And the thing about that is that people with intellectual disabilities who have these conditions might be at higher risk for severe illness from this infection. There's also the risk of being or living in an environment where one is exposed to or is what's might be referred to as a super transmitter. And so there's all that concern that we already heard about workers coming in or people with disabilities going out that carry the infection, maybe aren't even aware of it and could transmit it to others. There's the big impact of this on mental health. And I think we heard about that, you know, the boredom, the loss of usual activities. And when we're talking about 12 to 18 months, this can be a major factor. There's this other issue in the background of, you know, dealing with death and bereavement and just being aware that there will be deaths among people who know each other well, and all the important preparation that needs to be done about that and healing afterward. And then there will be changes or decreased caregiving and supports that people are used to. So this is another vulnerability that, for instance, if someone's caregiver themselves becomes ill, is there a plan of what to do in that case? And then the history of lack of involvement of people with disabilities in decision-making. And this, I think, is another vulnerability and something that we ought to address. So I think that this is sort of a key idea, which is to really talk about and think about health as sort of this balance between needs and supports, and that this is a dynamic sort of way of thinking about health. And I'll just flag, you know, some of these needs that in fact have to do with things like health habits. So, you know, diet, exercise, adequate sleep, and you know, social interactions, that those positive health habits need to be maintained, and negative habits need to be diminished if possible. You know, lack of activity, smoking, and things like this. Another one is just the management of health conditions. So, as I mentioned, many people will have other health conditions that are ongoing that need to be managed, such as diabetes. And just to make sure that we're not forgetting about those things and staying on top of them. Another health management issue is some new illness that might occur. And especially for people that might not be able to communicate that, to make sure that that is identified, say a fever, a cough, by someone, so that issues can be addressed. And then the third thing is kind of thinking ahead to the future, where we begin to think about preventing illnesses and trauma. And I'm going to focus a bit more on that, because that's where, you know, all the talk about social distancing, that's a preventive measure, but a healthcare plan is also about the future, that people might need some help in organizing. So on the other side, there are the supports, and we can think about those in terms of all these dimensions of supports, and the importance that I put personal caregivers up top, because they play a huge role in kind of addressing various needs, overseeing the management, and even thinking ahead on prevention. But then a key sort of point of access to healthcare would be the primary care team. And that would be the person who would normally help to coordinate and oversee all these dimensions. A next sort of category of supports would be specialists, both on the medical side and on the developmental side. And then finally, systems. And I think part of the challenge is that the systems that we're engaged in have to do with both health and developmental services. And even within health, between physical health and mental health. And there's sometimes for people with intellectual disabilities, all of these inputs are relevant, and they raise system issues. So I just wanted to talk, another way of thinking about health is to think about a coordinated and integrated healthcare plan. And this is just an example of the sort of plan that I would use, and it just helps to think about the various things that are going on and who's doing what, who's overseeing which of the tasks. So I think this is especially important in the context of a pandemic, that we are being mindful that there are many elements to health that need to be thought about, and some coordination and integration of that. So I guess all I would say is that the areas especially to track during a pandemic would be things like new symptoms, and caregivers have such an important role of recognizing those and alerting the family physician soon, because there will be things and decisions that need to be made, and the sooner the better. And also alerting public health and other supports. So another thing would be kind of what to do if someone develops severe symptoms, shortness of breathing or so on, and kind of what are the contingency plans about that, such as contacting emergency services and the primary care provider at a first available opportunity. And then the other thing that I had sort of just mentioned previously, if there's a new illness, and particularly in the context of COVID illness, are there any plans about the future? And that particularly about health decisions that need to be made, and this is what raises the issue of advanced care planning. So just to kind of illustrate that sort of the various elements involved in advanced plans and contingency plans. So this image is just showing that the patient is in the center, but there are many conversations that need to occur with that patient and others. And so I've sort of indicated that there would be decision-making supporters that might help to ensure that the person actually understands what's being talked about, and eliciting what their goals and preferences might be in a situation where they became quite sick with, say, a COVID infection. There's the role of the primary care provider in informing that discussion, and of a substitute decision maker, because ultimately advanced care plans are not consent to treatment. They are preliminary to proposals of medical care that might arise when somebody becomes quite sick and isn't able to talk about that themselves. And then the final point I put on top is this is complex stuff, and it usually takes a lot of time, but we don't have a lot of time. And if we believe that this is important, that people have a voice in what might happen and what they don't want to happen, what they do want to happen, that happens, it is important that these conversations happen. Just by way of example, we know in the general population that most substitute decision makers do not know what the person they're making the decision about or for, they're giving consent for, would have wanted, which is something that we really should try to avoid. But this is sufficiently complex that there probably needs to be a new role that somebody takes, if not part of the primary care team, that would facilitate these discussions and do them quickly. The other question marks that are on this slide are just to highlight the various sort of contingency plans that might be needed. So for instance, we've been talking about an advanced care plan that anticipates possible medical treatment proposals that might be made in that context. And that's what an advanced care plan helps to address. But then there's all these other situations, such as the sickness of a caregiver or in the home and how to manage that. Another one would be a mental health crisis that might happen if somebody have had something like that in the past, and are there plans to help manage that and keep people hopefully out of hospital in this context. So anyway, this is just to flag this whole idea of thinking ahead as part of prevention. We know that a huge issue for people with intellectual disabilities is trauma, and part of the remedy is to avoid and prevent trauma by being prepared. So I'll just finish by flagging that this raises also this whole issue of respecting inherent human rights, and to think of that as part of the human good. So one of the concerns, and I think this will be addressed in more depth momentarily by Brendon Pooran, is that in this context, all our advances in thinking for actually the last 70 years might be at risk because there may be no place for a conversation about basic human rights, and that there's a lot of concern that people with developmental disabilities, because they have a developmental disability, might be treated differently than others. And so it just raises this notion, this concern that how we as a society kind of manage the road ahead will depend a lot on how we care for one another, particularly those who are most vulnerable. So I think in conclusion, the COVID pandemic will last a long time, and it will change the ways in which people with intellectual and developmental disabilities access healthcare, and in the short time as well as in the long term. And it doesn't need to be all bad news. We should not be paralyzed by fears and anxieties, but see an opportunity for positive outcomes. So in the short term, continue to maintain healthy habits and ongoing management of health conditions, adjusting supports for persons with IDD as needed, and being prepared for health crises and contingencies. In the long term, hopefully, the habits and innovations that we as caregivers, care providers, and a care system develop will remain, such as assiduous health monitoring and preventing of illnesses, involving persons with intellectual disabilities in decision-making, especially in developing advanced care plans and contingency plans, and better and more frequent virtual communication to establish cooperation and integration among caregivers, primary care team, specialists in both medical and developmental services and systems. So I'll just close by flagging, practical things that will be needed if all of this is to be helpful. And this is just examples of things that can be found and that we're working on at the Developmental Disabilities Primary Care Program and Surrey Place. And here are some additional resources that people can consider. So thank you very much, and I would welcome your questions.
Okay, thanks, Dr. Sullivan. We do have a few questions for you. It looks like we have a few, at least a few, I think quite a few parents on the line. So we have a couple of related questions here. The first is, how can I accompany my daughter who has a disability if she were to become ill? Is it true that I couldn't go with her? And then we also have a question saying, hospitals are not allowing entry of staff to accompany the person supported. How do you ensure safeguards are in place?
Yes, that's an excellent question and a very important concern. And I think that we can look to some guidance on this from our colleagues in the United Kingdom who have actually published guidance on this very issue and are insisting that there be exceptions made for people who require such supports. So, really the concern is really the spread of the infection. but there are other concerns, and there has to be, the system, I think, needs to be mindful of that this is part of basic care to ensure that the supports are available for people. You know, if that is not always possible, then that should be part of the contingency plan. If you can't be there, what are some other ways to provide those supports? What could go with the person? Say even, you know, a communication board that's hung up in the hospital room, for instance. Or, you know, I think Joanne was also talking about the importance of, you know, having electronic devices that one could, you know, communicate through, you know, phones or iPads and things like that. But it is a very important system issue, right? If there's a policy that nobody is allowed to come into a ward that might be designated as for people with COVID, you know, that's a valid public health concern, but there's also valid concerns about how do we support people in that context. And if it's just an issue of people needing, you know, the protective equipment that is needed when they go into such a ward, I think there's a good argument to be made that they ought to have it to provide those supports.
Okay, thanks, Dr. Sullivan. A second question is about regular mask use and homemade masks. Someone has said that their local public health has been asked several times about regular mask use and homemade mask use, and they are not advising homemade mask use at this time. Could you provide some perspective on that?
Yeah, so yeah, that's a tricky question in the sense that it's one of these uncertainties, I think. What is clear is that the idea of the mask is actually not so much protection of the person as normally it's to prevent the person who has a cough or a sneeze from expelling droplets. So it's basically part of what's called respiratory etiquette. So the concern is that we don't know if the person coming into a group home might be infected. It's an unfortunate uncertainty about this virus, and I think that can be, you know, kind of overstretched how big a risk that is. Hopefully, with more availability of rapid testing, which was just announced, we would be able to kind of rapidly check people to make sure that they weren't infected. So just in terms of a barrier, you know, having, you know, if you're coughing or sneezing, having anything in front of your mouth, even the sleeve of your shirt, that's part of respiratory etiquette, so that you're just not transmitting it. Now, whether a scarf or other thing, homemade thing, would do just as well, I think I'll leave that to other experts, but it's better than nothing. And I think that there is a valid concern that all the masks will be used up. Now, I think the further question is that if we're talking about a group home, say, and somebody in the home is actually tested positive or is suspected of having the virus, then how do people protect themselves? So that's a different situation. It sounds like already, though, people are using masks all the time, which is being, I think, quite, you know, cautious. So I guess the question would be that it is a different situation when there's somebody who's COVID positive that is being cared for. And I would need to leave it to others to know whether that is actually a situation that, you know, most group homes would be able to deal with. I think, you know, that's the question of, you know, you really do need proper equipment if the person providing care has never been exposed and might be at high risk. And you also need what are called viral firewalls, so that the separation between, even within a home, going between one person and another needs to be a bit of a firewall, viral firewall, and also coming into the home and going out of it. So it's basically part of a much bigger sort of infectious diseases question of minimizing the spread.
Okay, thank you, Dr. Sullivan. Again, we have to move on in the interest of time, but your questions are incredibly important. We are recording them, and we will study them after the webinar is finished, and they will absolutely inform Community Living Ontario's work on this issue going forward. So please do continue to send us in your questions.
Thank you very much.
We're going to move on now to Dr. Lunsky.
Hi, everyone. Wow, so much information already that has been shared, and really such excellent speakers, and really important things, sort of important innovations, important things being emphasized. So I'll try to sort of just add on a little bit, and I have different hats, we all do. So I'll just mention I have I'm the sister of someone with a developmental disability who gets support from agencies here in Ontario, and I'm so grateful for that. I also have lots of worries and concerns as a family member. I'm a researcher, and I direct a program called HCARD, which really focuses on what we know about the health of people with developmental disabilities, as Dr. Sullivan kind of hinted at, but also what we can do to make things better. But I'm a psychologist, so I work at CAMH, and I focus on mental health. And so I think my comments today will sort of have a little bit of that focus. So if we go to the next slide, I'm sure people have all become what they call sort of couch-based epidemiologists. We've all been looking at a lot of graphs lately, whether we understand them or not. But I thought I could do my entire presentation just talking about this graph. And the citation for this graph is Twitter. So Vector Sting is his Twitter name, but his other name he goes by during the day is Dr. Victor Tsang, and he's a physician. And he just put this graph out as a kind of idea when we think about COVID and different waves of COVID, sort of a different way to think about it. So these aren't sort of proven numbers. It's more sort of a way of thinking about it. And I'm going to sort of try to break it down with you and focus on, in particular, the red line or the fourth wave. So what we're all hearing about right now, and what we've heard about in terms of actions from the community agencies, actions from healthcare, people like Dr. Sullivan, is this first wave, which is this work we're doing, the purple line, where we know this pandemic has started, it's going to hit a peak, and then it's going to slowly go down, and it's about trying to reduce how many people get very acutely ill and require a lot of hospital-based care. But COVID is doing a lot of other things in addition to people having COVID. So the green line here is really talking about, because, for example, we've canceled, I heard, from Community Living, from Joanne, she talked about someone who was diagnosed with cancer during this pandemic. Well, surgeries related to cancer and related to other kinds of procedures, maybe a hip or a knee replacement, or other kinds of elective procedures, and sometimes some very important ones, are being delayed, postponed. And so another thing we're going to start to see is that people who really urgently need other types of care are waiting longer than they normally would, maybe, to get that kind of care. Now, the blue sort of line that we see is what they're calling the third wave. And that's saying that over the course of all this stuff, we have a number of chronic conditions that we're not paying as much attention to as we could. And that's going to impact all of us, maybe more so after the sort of initial urgent stuff is out of the way, but it's going to be there. So how are we managing diabetes? How are we managing, people who need to get their glasses fixed or replaced, or dental stuff, and they can't see their dentist right now. They can't get their eyes checked. They're having hearing issues. They're not sort of testing their sugar necessarily properly, or getting a sort of review of their medications around their epilepsy. All kinds of things can start to happen for people with chronic conditions because of, A, the delays in getting care, but also people's kind of fear or reluctance to want to get their care right now, because there's this idea that I should be staying away from healthcare, right? Or this isn't important enough. So all those things are sort of happening at the same time as the COVID. But I want to talk about this red sort of line that we see here. What it's showing us is that over time, we're already getting incredibly anxious, incredibly frustrated, and some of us very unhappy and even depressed. And this kind of trauma that we're all experiencing, mental illnesses that are sort of emerging, as well as the ones that were already there, but aren't necessarily getting the treatment they're used to, that's going up, and that's going to stay up for some time. And I wanted to talk about this in our community, in the developmental disability community, because all of these things affect us. But I think one that affects us in particular that I want to focus on is what happens around our mental health. We know that this group is, as was already mentioned, more likely to have mental health issues at the best of times, and have difficulties accessing mental health care, restrictions when it comes to different types of therapies beyond just medication. But now there's all this other stuff happening as well. So there's, like we said, the isolation, the lack of routine, not being able to sort of predict or organize your day, a lot of fears and sometimes confusion. If you don't understand what the rule is, maybe you get that much more scared about it because you're actually interpreting things much worse than other people might be doing, right? And also this sense of hopelessness, when will this end? Another really important point around mental health that I think we're seeing in our community is, you know, there's the mental health of the person who has a developmental disability, but there's also the mental health of the people around that person. So caregivers, for example, and it could be family, it could be siblings like myself or parents, but it's also staff who are working in the sector who are really anxious about things that are going on right now and who are also potentially dealing with other things related to COVID in their own families or in their own lives. And something happens with us with mental health. When one person is really stressed out, so are the other people around that person. So whether it's the person with a disability who's struggling or caregivers and people supporting that person, they're feeding off of each other. And so I think that's making some of our mental health issues worse. And I mean, I do want to give one message out there is that healthcare is not closed right now, and mental health care is really not closed right now. It's just a bit different, but it is still accessible. So certainly for everyone listening who's thinking about this, you can still contact your family doctor. You can still contact different mental health teams. It's just that you can't go in for your regular appointments. Which brings me to my next point, and we don't even have to switch slides yet because I have very few slides, but I will go to my next slide shortly, which is that a lot of what we do to prevent, oh yeah, it's okay, no, you can go. Good. A lot of what we do, if we go to the next slide, to prevent mental health issues right now, as well as some of the other issues, is we think about virtual ways of connecting with people. So we can, as mentioned earlier, we can have a virtual sort of visit with a mental health care provider, but we can also go and use online resources. We can connect with different sort of social connections with other people that are online. There's all kinds of things that we can be doing to be supporting our mental health. So here I have just two quick examples, and we heard about some great examples happening from the Parry Sound Community Living Agency. Is we have a page here that we have a lot of resources and ideas around how to help people stay connected through HCARD. And then we have a visual of an activity that goes on Fridays called Fit Fridays, where people can join on video conferencing through software kind of like this, and they can actually see themselves as well as the other people participating, and they're doing a fitness activity. We have different kinds of activity like that to happen every day. Now, I thought if I would have given this talk 2 weeks ago, I totally would have been pushing for more technology and more ways for us to virtually be sort of supporting and promoting mental health as well as accessing mental health support. I even wrote a blog about it, which you're welcome to read, called Time for Tech. But I have to say that since I wrote it and since I've been thinking about this in more recent days, I have a question mark when it comes to Time for Tech, because I realized that some of us are getting teched out. Okay, so I don't know for you how many of you are starting to read your emails a little bit less. When you go to a web page, there's so many web pages, you stop clicking on everything. But more importantly, some people were never teched in the first place. So to have demands for people to meet their mental health requirements through virtual ways of doing things, through websites, through links, when people aren't necessarily used to doing that, is really difficult for them. So it's really important, I think, for us to be thinking about ways beyond our technology to support ourselves and other people. So thinking about simple phone calls, dropping off of information as we saw sorry, I'm not quite on that slide yet, but I will be there in a second. For example, you know, taking something to someone's door, letting them know it's there, and then maybe calling if you can't speak to them from their porch and talking to them about what's in that package after. So we make this mistake where we write something fantastic on our website and nobody clicks on the link. Well, these are people who aren't necessarily using links. Maybe they need to see it on a piece of paper. So how do we think about who's using technology for mental health and ways to help people who feel overwhelmed by technology to help them at the same time? So my last slide is just to highlight a few things that I think we can do, all of us, I think, to promote our mental health. So the importance of routine, but recognizing at the same time, while we're recreating or coming up with new routines, that we also need to be thinking about flexibility. So Shelley Moore, who talks a lot around that inclusive education from BC, talks about don't shit on me. And I think that's a really good point. So we should have routines. We should be doing things at a certain time if that works and if creating that routine or structure is helpful. But sometimes we don't need that and we need to have some flexibility. And that certainly goes for the people that we're supporting with developmental disabilities. Whatever it is that everyone is doing, people still need meaning in their day. So thinking about not only how we can help people with developmental disabilities, but how they can help themselves and how they can help other people. And things that people can actually do so that each day there's something they're doing that feels meaningful, whether it's helping to clean their space or making a card for someone or reaching out on the phone to somebody else who's feeling scared or worried. Validating, a big part of what helps us right now is recognizing, you know what, it is really tough. I'm also angry or I'm really scared. It sounds like you're feeling really scared right now. I get that. And feeling or knowing that the feelings we're having are shared by other people and that we're being listened to is incredibly important, especially for people who sometimes feel like they're not being listened to. Knowledge is power. So sometimes we are confused because we don't have information or we don't understand the information available. So we need to be thinking about how to translate information to help reduce people's anxiety and fears, but also help them to make the right kinds of decisions. So I heard the questions being asked before around masks, for example, or understanding what would happen if I had a difficulty and I had to go to the hospital. Helping to make sure that the knowledge is shared across all people, whether or not you have a disability. Making sure everyone in this limited, restricted time get to still make choices about what they're doing. Knowing that we're all part of a larger community and feeling like we're part of that community. And again, keeping in mind if people are less connected to technology and we can't support those connections through technology, how we message that they are part of a community. And finally, just pausing and taking 3 breaths. So some of the work that we're doing at our center, and you can find the information on our COVID page, is looking at how we're sharing, for example, simple mindfulness strategies. And I'm going to do something a little bit risky. I'm going to take 1 moment out of my questions and ask everyone to just stop everything they're doing and practice the skill that we do with our mindfulness groups, whether it's people with disabilities or families or healthcare providers, and just stop and take 3 breaths. We used to call it the 3-minute breathing space, but we realized that even that felt too long for people sometimes. But sometimes we can all actually just stop and breathe. So I'm going to close my eyes for a moment, and I'm literally just going to stop everything, and I'm going to take 3 breaths, and I invite you to do the same. Sometimes we think things are going so quickly that we have to join and get on that train and go as quickly as everything else, and we don't stop. We don't stop to notice what's going on right in front of us in ourselves. We don't stop to notice what's going on with the people that we're supporting with developmental disabilities. And I think all of us sometimes need to pause, and that's a really important consideration when it comes to mental health. So my last slide just gives links to some of the resources that we have. This is reminding staff who work in the sector from all the agencies in Ontario that we are doing an ECHO, which is a way of building capacity or skills of people working in the sector during COVID. And it's virtual just like this, only we can see and hear each other. And there's teaching during each ECHO that goes on, as well as case-based presentations and discussions. And you can register for the 6-week course. You can take all 6 weeks or just 1 or 2 if you like. And more information about that I can share on our hcardcovid.com page. And then here's the links to that page and other things through our program. and I can take questions.
Thank you, Dr. Lunsky. Those 3 breaths were actually surprisingly helpful for me this morning. So thank you for that. In many ways, you really have been answering people's questions directly in your comments. Now, there was a question about individuals with autism in particular. Do you have any advice to staff who are supporting people with autism? Are there particular considerations you might have as opposed to your more general guidelines around mental health?
I guess one comment I can make is sometimes when we talk about autism, we talk about autisms. So just like people with developmental disabilities are not all the same, people with autism or people who identify as autistic are not all the same. One person might be very much needing routine and having a really hard time because that routine isn't in place. Another person might actually be liking the fact that they don't have to get up and go at a certain time to a particular day program or activity, and that they get more flexibility in their day. So I think we need to keep in mind the diversity of the people that we're supporting regardless of their diagnosis. There are a number of different websites out there that I think are helpful, and there's also a number of sort of webinars and different experts speaking about things that are helpful at this time. But I would make a comment that we need to think about what makes a person an expert. We have some clinicians sharing their wisdom, and I'm a clinician, talking about what's useful in autism. We have family members talking about what's useful for them as a parent or as a sibling. And then we have autistic people talking about what's useful for them. And I'd invite you to look at all those different types of resources because there's something helpful from these different perspectives, and they're each important. So again, on our hcardcovid.com site, we mentioned a few, but there are a number of things that are coming up. So we have always, I think, looking to self-advocacy organizations to see what things they're producing for themselves, as well as looking at things like, for example, what you might see through Autism Ontario more locally. But I don't want to feel like I'm endorsing or not endorsing different groups. There are a number of things out there that I can share sort of offline after that you can see from our HCARD site. We do have, I mentioned the Fit Fridays. We also have our Mindful Mondays. Today, it's not too late. If anyone who has a disability themselves wants to join our Tune In Tuesday, it's at 3 p.m. and it's sort of mindfulness strategies for people with intellectual disabilities or with autism. And then another really important thing that came up, I heard this from Joanne, is this idea of questions. We had parents asking questions to Dr. Sullivan. We have a lot of questions that people with disabilities are asking as well. So we have What's Up Wednesday starting tomorrow, where we've taken some of these questions, and then we have different doctors and nurses giving answers to some of those questions. So that's all those things are available on our site, and we'll see to everyone.
And then finally, someone has asked about advice you would give to someone supporting a person with a developmental disability who is being neglected or seemingly not getting the same level of care with as a person who does not have a developmental disability. Is there advice you would give someone on managing their reaction to that kind of situation?
It's a big question. One thing I would emphasize again, which I said before, that's really important. There's different types of care people might not be getting that can concern us right now. And I know we'll be hearing from Brendon after around sort of our legal rights or sort of issues around that side of things. But on the health side, I think highlighting or noting what's not happening and working as closely as possible with the primary care team, with the family doctor and nurse practitioner, or possibly mental health people, really highlighting what's needed and figuring out if there's a way to get it is really important, and helping that person advocate for that. I think sometimes I find there's different times where we're like sort of the really angry person demanding stuff, and times where we're the collaborative person trying to work together to figure out stuff. And depending on how time sensitive an issue is, how we do that, I think, and where we fall in that range is going to vary. But I think it's helpful to recognize how stressed everybody is right now, and that sometimes what we're doing that is harmful to people is not purposeful, but is sometimes because of not realizing how much is needed, or because of the stress other people are encountering at this time as well. So a little bit of compassion that we give to ourselves, and that we also give to people with disabilities, to have that awareness, I think, in our approach as we do our advocating, I think is really important. But also knowing about clear examples of where things have gone well and what things might be helpful, and sharing that information in a very clear way, can also help in terms of advocacy efforts.
Okay, thank you so much, Dr. Lunsky. That's incredibly helpful. We are going to move on to Brendon.
Okay, great. Sean, can you hear me?
Yep, we can.
Okay, great. Well, first of all, I'd like to thank Community Living Ontario for inviting me to be part of this webinar, and also to my fellow co-panelists for their collective wisdom and expertise. Your commentaries so far has been incredibly informative and enlightening. In terms of my talk here today, I'll first provide you with a very brief background into the various legislative frameworks in place to protect the rights of people with disabilities under international, federal, and provincial law. This will provide some context for the second part of the discussion, which will speak to a few of the legal issues that we've come across over the past month related to COVID-19 and the provision of healthcare to people with disabilities, both in healthcare facilities as well as in their homes. As you can imagine, there have been numerous issues that have come up. But given the time constraints that we have here today, I've decided to focus on 4 of them. So if we can just go on to the next slide. The 4 issues that we'll cover relate to consent to treatment, privacy, the duty to accommodate, and the provision of home care. I think these topics are especially important given the disproportionate impact of COVID-19 is having on this community. A recent article in the New York Times cited that people with disabilities are over 5 times more likely to develop COVID-19 and nearly 5 times more likely to die from it when compared to the rest of the population. In addition, at home here in Ontario, a draft version of a document entitled the Ontario Clinical Triage Protocol for Major Surge in COVID Pandemic has raised some serious concerns. The protocol establishes guidelines for rationing critical care and resources as a health system reaches operating capacity during the pandemic. As drafted, the guidelines could result in some people with disabilities being deprioritized for critical care on the basis of their disability. Arch Disability Law Center has led a response on behalf of the disability community, which calls for amendments to the draft protocol that respect the human rights of people with disabilities to accessing and receiving healthcare, and ultimately that the pandemic cannot be used as a justification for discrimination. Okay, so moving on to the next slide. Again, I'm just going to provide you with a brief background about a few different legislative frameworks. Internationally, the United Nations adopted the Convention on the Rights of Persons with Disabilities, also referred to as a CRPD, in 2006, of which Canada is a signatory. The objective of the CRPD is to advance the recognition and realization of the human rights of people with disabilities. In particular, I'd point you to Article 25, which speaks to the requirements that the signatories must recognize that persons with disabilities have the right to the enjoyment of the highest attainable standard of health without discrimination on the basis of disability. So non-discrimination is really central to the CRPD and is critical for ensuring equal access to healthcare for persons with disabilities. Moving on to some federal legislation, and we'll keep on going to the next slide. Great. Federally, we've got the Canadian Charter of Rights and Freedoms, and this lays out constitutionally entrenched protections for people with disabilities. All legislation and policy in Canada must be charter compliant. So regardless of whether or not we're talking about federal laws, provincial laws, or municipal laws, they must all be consistent with the charter. For our purposes, section 7 and 15 of the charter are especially relevant to healthcare services, where under section 7, life, liberty, and the security of the person is protected, and the right to life is engaged where the law or government action can result in death or puts life at risk. And section 15 speaks to or protects against discrimination on the basis of several grounds, including mental or physical disability. So we'll circle back to the charter a little bit later in the talk. Moving on to the next slide. So there are a few pieces of provincial legislation that are especially applicable during these times. First, the Ontario Human Rights Code is quasi-constitutional legislation that protects the right to equal treatment based on several grounds, including disability. So similar to the protections available under the Charter. Next slide, we've got the Accessibility for Ontarians with Disabilities Act, which is commonly referred to as the AODA. The AODA states that goods and services must be provided in a way that respects the dignity and independence of people with disabilities. In particular, the AODA's customer service standard requires that any provider within the healthcare context provides service to the public in a barrier-free manner. Next, we have the Healthcare Consent Act. The Healthcare Consent Act provides rules with respect to the provision of consent within healthcare settings. So we're talking about consent to treatment, consent to long-term care, and consent to personal assistance services. In particular, it provides that everyone is presumed to be capable of making their own healthcare decisions. So that's sort of the basis of where health practitioners should be starting. Only in a situation where someone is considered incapable of making their own decisions does the healthcare practitioner seek the consent of what is referred to as a substitute decision maker. And again, we'll circle back to this topic in just a few minutes when we talk about some of the legal issues that have arisen. And finally, we have the Personal Health Information Protection Act, commonly referred to as PHIPA, and this governs the collection, use, and disclosure of personal health information about people. In particular, it provides the confidentiality. It provides for the confidentiality of personal health information and the privacy of individuals with respect to this information. And like healthcare consent, there's a presumption that everyone is capable of consenting to the collection, use, and disclosure of personal health information, and only in situations where somebody may be deemed incapable does input from the substitute decision maker get sought. Okay. Moving on. So now I'll turn to some of the legal issues that, again, have arisen over the course of the last month with respect to the provision of healthcare and issues that people with disabilities and their families may be encountering that are sort of specific to COVID-19. So let's first look at informed consent to treatment. Sometimes there could be some confusion in this area of the law because it does have some gaps. There is quite a bit of gray area, and it can be difficult for some people to understand generally, and especially within the context of COVID-19. Not only from sort of a treatment perspective, but also when it comes to even consenting to being tested. So again, the law starts with there being a presumption of capacity. Everyone is presumed to be capable of making their own healthcare decisions unless a decision actually has to be made and there is evidence to suggest that the person may not be capable of providing this informed consent. The test that should be applied by the healthcare practitioner is sort of a two-part test. The first branch speaks to the person's ability to understand information relevant to making a decision. And the second part speaks to the person's ability to appreciate the reasonably foreseeable consequences of that decision. So can they take the information and apply it to themselves? It's important to note that no treatment can be performed or carried out without someone providing informed consent, except in cases of emergency situations. Moving on to the next slide. So in situations where somebody may be deemed incapable of consenting to their own healthcare treatment, the Healthcare Consent Act provides for a hierarchy of what we call substitute decision makers. So again, if I'm in hospital, I'm considered by that healthcare practitioner not to be capable of, let's say, consenting to a test or consenting to treatment, only then does the healthcare practitioner seek input from my substitute decision maker. So this slide here sort of lays out what that hierarchy looks like. The first three sort of categories there highlighted in yellow are legally appointed SDMs. So the first one is a guardian, and a guardian has to be sort of appointed by the court. The overwhelming majority of people do not have legally appointed guardians in place. The second allows a person to appoint an attorney for personal care by way of a power of attorney for personal care document. And we're going to speak a little bit more to that in just a few minutes when we speak to advanced directives. The third relates to a representative being appointed by the Consent and Capacity Board. Now, if none of these legally appointed representatives are in place, we then go down to sort of the green section. And the green section alludes to the fact that without any legally appointed SDM, a family member would automatically take on that role. And family members are also ranked. So first we have a spouse or a common law partner. If there is no spouse or common law partner, then parents or children of the individual have the right to step in and act as a substitute decision maker. If there are no parents or children, then we get to siblings, and without siblings, any other relative. If there is absolutely no family in place, then the public guardian and trustee would sort of be the SDM of last resort. I'd point out that service providers are not on this hierarchy. So it's especially important, I think, for service providers to realize that if there is no court-appointed substitute decision maker and there is no family in place, unfortunately, in order for informed consent to be provided, it would likely require you having to consult with the public guardian and trustee. Again, that is not really a solution, but I would say an option of last resort. Moving on to the next slide. And Dr. Sullivan did an excellent job of providing an overview around advanced care planning. From a legal perspective, what this may entail is the execution of what's called a power of attorney for personal care. Power of attorney for personal care is a legal document that anybody the age of sort of 16 years or older that sort of meets the capacity requirements to execute one of these documents should do. It essentially allows you to appoint a substitute decision maker in the event of your incapacity. It allows you, I think more importantly, to identify any sort of specific wishes related to treatment and to clearly articulate those wishes. And keep in mind that the power of attorney document doesn't only apply to healthcare decisions. It applies to not only healthcare, but hygiene, shelter, nutrition, safety, shelter, and clothing. So all aspects of your personal care. If a person does not have a power of attorney document in place and they are sort of deemed by the healthcare practitioner as being incapable to consent to treatment, then it's important for there to be some sort of documentation or somebody present that can identify who the legally authorized substitute decision maker is. So is that mom? Is that dad? Is that a sibling, and if it is a sibling, then which sibling is sort of responsible for taking on that role. Keep in mind that substitute decision makers have to act based on the individual's prior capable wishes, and only if there aren't any prior capable wishes in place does the substitute decision maker then act in accordance with the person's best wishes. I'd say it's also important to have a list of people to contact for support should the individual require additional supports. Moving on to the next slide, we spoke a bit about PHIPAA a few minutes ago in relation to privacy. And this piece of legislation, again, governs the collection, use, and disclosure of personal health information. Similar to treatment, informed consent is required in order for a person or an entity to collect, use, and disclose someone's personal health information. If the person is incapable or deemed incapable of providing this consent, that hierarchy that I just went through with respect to consent to healthcare treatment applies. So the substitute decision maker would step in and provide that consent. Now, some issues that have sort of come up over the last few weeks is, you know, if I'm a family member or if I'm a service provider, how can I demonstrate that I have, let's say, the authority or the person has consented to me when it comes to the sharing of personal health information, such as, let's say, the results of a test for COVID-19. The documentation is especially important to address this. So again, power of attorney for personal care can help in those situations, but regardless of whether or not the person is deemed capable, I would say that having the requisite sort of consent forms in place would go a long way when it comes to allowing healthcare practitioners and healthcare facilities to share information with other people. Moving on to the duty to accommodate. So we'll now turn to healthcare providers' obligation to accommodate the needs of people with disabilities, consistent with human rights legislation. As I stated a bit earlier, the Human Rights Code applies within the healthcare context and states that providers have a legal duty to accommodate up to the point of undue hardship. This means that service providers like hospitals or healthcare providers must respect the dignity of people asking for an accommodation and take an active role in seeking accommodations that meet individual needs. The duty to accommodate may allow or may include allowing a support person to accompany the individual to the hospital to provide communication or interpretation support. We think of these I think of this within the context of policies limiting visitors or family members in accompanying the individual to hospital. Without downplaying the safety risks associated with COVID-19, having that support person in place may be vital to the person's health and well-being while in hospital, and must be strongly considered when developing and implementing these policies. And I think Dr. Sullivan again spoke to this quite nicely. He sort of cited the NHS guidelines in the UK that allow specific exceptions when people require additional supports, and beyond just the support, beyond just the accommodation of having support people in place, he also cited other means of accommodations, such as electronic devices and communication boards. And finally, some concerns have come up within the context of providing care in a person's home. So issues have been raised by both people receiving care as well as service providers with respect to how best to provide nursing supports and help people with activities of daily living during the pandemic. Ontario has classified home care services and personal support services to people with disabilities as essential during the COVID-19 outbreak. Note that during the pandemic, the Ministry of Health has also released guidelines for home and community care providers. The guidelines include the screening of people receiving service by phone before appointments and asking about who will be in the home during that appointment. If a person is a suspected or confirmed case of COVID-19, care providers must take precautions such as proper hand hygiene, wearing personal protective equipment, and instructing patients to wear a mask if this is something that they are able to do. As with human rights protections, however, such guidelines cannot be and must not be implemented in a manner that is or must be implemented in a manner that is consistent with a person's rights under applicable legislation. In particular, not only the duty to accommodate and human rights legislation, but providers must still adhere to the Home Care Bill of Rights, which is incorporated into the Home Care and Community Services Act. So I believe that's all the time I have, but I'm happy to entertain any questions that the audience may have.
Okay, thanks, Brendon. We do have a few questions for you. The first one is it looks like it's from an organization that has some congregate care. The question is, can a group care facility apply to be a substitute decision maker of a youth who has recently become of legal age? Under what grounds, if any, would the facility have to become the substitute decision maker?
It's a good question. I think the short answer to that question is no. A provider, a service provider, cannot apply to become a substitute decision maker. If we, I referred you sort of to that hierarchy of substitute decision makers under the Healthcare Consent Act, and really outside of court-appointed guardians, people appointed through a power of attorney document or by the consent capacity board, and other than family members who may be legally authorized to act, there are no other options outside of the public guardian and trustee's office. So the short answer to that question is no. Service providers can't apply to become substitute decision makers.
Okay. On a related note, someone has asked, does a power of attorney come into effect only once a person's capacity is diminished?
Yeah, when we speak of a power of, so there are two types of powers of attorney in Ontario. The first one deals with a person's personal care. So again, covering healthcare, hygiene, nutrition, safety, shelter, and clothing. That document does only come into effect, or the attorney identified in that document is only legally authorized to act if the person themselves is deemed to be incapable of making a specific decision at that point in time. A continuing power of attorney for property, which governs decisions related to finances and a person's property, there is an option for that document to come into effect upon it being signed, or the attorney's authority being triggered upon incapacity.
Okay, thanks, Brendon. Additional question is, someone has asked, if we have a presumptive or confirmed case of COVID in our group home, what is your recommendation as to how to inform families based on rights and privacy? What can we say and or not say?
Yeah, I'm not sure that we can cover all of those aspects here today. I think Joanne did an excellent job of speaking to the importance of timely communications out to families and other stakeholders. I think I've cited some concerns related to privacy and the protection of people's personal health information. And so it's always trying to strike this balance between informing your various stakeholders in order to sort of mitigate risks, mitigate any kind of safety risks with protecting the privacy of a person's personal health information. So I would say, if you've got specific questions related to a suspected or a confirmed outbreak, feel free to sort of follow up for some advice specific to your situation.
Okay, and again on substitute decision making, we've had a number of questions on this. So Brendon, I wonder if it might be helpful just for you to review a situation where there's no one related to a person in their life who's available to act as a substitute decision maker.
Yeah, and unfortunately, that's where some of the gaps in our legislation exist. And again, Dr. Sullivan spoke to the importance of sort of supported decision making and identifying people in the person's life who may not be legally authorized to act as a supported decision maker, but may be a trusted friend who may be able to interpret that person's will and preference and that person's sort of wishes. From a purely legal standpoint, if there is nobody in that person's life who would fit within the context of that hierarchy that I provided, then unfortunately the public guardian and trustee's office would have to be contacted if a specific decision had to be made and that person was deemed incapable of providing informed consent.
Okay, thanks, Brendon. And then a slightly different question outside of the healthcare field is around any legal issues related to if an agency requests for staff to only work for one organization during the pandemic.
Yeah, and not something that I would say I can answer directly. I know that we've had to address that issue on numerous occasions, and it's something that I would sort of defer over to our labor and employment group. I believe that there may be a blog related to this topic on our website, and if not, we'll be definitely covering it in one of our upcoming webinars.
Okay, and then perhaps one last question. Should a parent of an adult with a severe intellectual disability apply for legal guardianship given everything that's happening right now?
Well, and I think we need another few hours to talk about the shortcomings of legal guardianship generally, but I think within the context of what's happening right now, again, I sort of provided that slide that laid out the hierarchy of substitute decision makers. And so really, if we're talking about consenting to treatment within the healthcare context, and a person is deemed to be capable by a healthcare practitioner of consenting to a specific treatment, legal guardianship in most cases is really not going to provide any kind of additional legal authority because parents are listed as legally authorized substitute decision makers on that hierarchy.
Okay, thank you so much, Brendon. So we have about 7 or 8 minutes left. I just want to take an opportunity to thank all of our speakers. We have just an incredible level of appreciation that you've taken the time to provide your expertise today. I'm wondering if perhaps we can end on a question for everyone to chat about if they like, and all of the speakers. The question is around for people who are living in the community. So I'm assuming the question means not in congregated care. Who takes on the lead role for a coordinated plan during the pandemic? You know, there might be a health-related focus right now versus more of a supports to independence focused. So does it make sense for health sector agencies to take a lead position in providing supports to people?
So this is Yona, and Bill, we might end up saying the same thing, we might say something different. I think we can't dictate that it will always be the healthcare provider or it will always be the community agency. I think the more important question is to respond quickly and to make sure that every person in the community, especially if they're not in a congregate care setting, has someone helping to think about that coordination. And making sure that that's, because what we don't need is for someone in Joanne's agency and for Bill to be working at the same time trying to do the same thing without communicating with each other. So someone needs to take a lead, and then we need to know who that circle of care is so it's being communicated across people, and it needs to happen quickly. So I'm thinking about collaboration here, but flexibility in the approach depending on where someone is and who is most engaged or feels most ready.
Yes, Bill Sullivan here. I really just flagged that issue because I certainly see it in caring and actually providing consultations to family physicians about the care of people with lots of things going on, and actually recognize that there is nobody that has that job. And so, but it is an important job just because there's so many players involved. And so I think that, it's part of the conversation of a circle of care, that somebody needs to kind of, be the note taker, taking a lead to sort of implementing or facilitating these discussions. And right now, there is no such person who has made that their job. There's lots of people who can do it. I suspect often what happens, it's a family member or sometimes somebody in the primary healthcare team, social worker or someone else. But it could also be somebody from developmental services who actually knows the players and could help to facilitate those conversations. But it's really not to say somebody like who that should be. It's just to flag that is a need and an important role.
Hi, it's Joanne. So with people that we support in Parry Sound, we definitely would take the lead role, but it's very collaborative. We work with community mental health, we work with the APSW. Right now we are working with community officers, managers of public housing. We take a community-wide perspective. However, if someone was to test positive for COVID, we would be definitely looking to public health to take the lead role in that, as well as the person's healthcare team. And we would absolutely support them in whatever way we could. But that certainly is our greatest challenge now. Our group homes are really locked down, but trying to keep people safe who live in their own apartments and community is our absolutely our biggest challenge right now.
And I echo everyone's comments. I think the only thing I would add is that, again, this speaks to the importance of getting advanced care directives in place and trying to anticipate all of the potential issues or all of the potential decisions that would have to be made should an illness be confirmed, and also to the importance of ensuring that, again, whatever kind of coordination that takes place or any kind of wishes that are identified are well documented and accessible and can be easily shared with healthcare practitioners in the community.
Great. Thank you so much, everyone. I know that I've learned a ton today. I also want to thank the audience for spending 2 hours with us. We had almost 500 people on this webinar, which is really incredible. A recording of this webinar will be available. It should come out to you later today. There should be a link that you can access, and please feel free to send that to people that you think may benefit from watching. And lastly, our next webinar is scheduled for May 6th. The focus of that webinar will be on the family perspective on developmental disability more generally. And I thank you very much, and have a great day, everyone.
Thanks a lot.